A very good morning and thank you for giving me this opportunity. Thank you, Dr. Aisha. The topic I'll be discussing will be the refractive lens exchange, the tips and the tricks. So, what is it? It's just a glorified cataract surgery without cataract, because the indication here is not just removing the cataract but for the correction of the refractive error. This is an old wine that is being delivered in a new bottle. This was there very long ago with the term clear lens extraction, but now the lens need not be clear always. And not only that, we are actually doing it for a specific purpose of giving a spectacle independence, and we are fortunate to have advances in the phaco-dynamics and better intraocular lenses that we can provide it. But are we justified in doing this? That's the question. So we need to understand some relatively newer concept, that is the dysfunctional lens index. So when we speak of lens, we always think about the transparency of the lens, but when we look at the lens as a functional organ, there is some other functional loss also that happens before the transparency is lost. That is being quantified as stage 1 and 2 in dysfunctional lens index, where the lens flexibility, the quality of the lens, quality of the light that is being transferred through the lens, that is by checking the scatter as well as the transparency of the lens. So these are the patients where we sometimes find in the OP, they come to us, they may be having 6/6 vision with best correction, but they say as they age, they feel that my vision is not as good as it used to be in the younger age. So it is being quantified, and it is quantified as normal, moderate and severe. When the lens index is less than 5, it is supposed to be severe because the quality of the vision they perceive is very bad. Based on this, the lens function quantification, now the term better used is dysfunctional lens syndrome, in which they take the presbyopia, higher order aberrations, as well as the lens opacities or the loss of transparency into account, and they have graded into grade 1 and 2, grade 1, 2 and 3. And in this, the grade 1 and 2 are those category of patients which we call as the pre-cataract or early cataract, and we try to find a solution for them because the quality of vision is not clear. So putting that in mind, the actual term that is proposed now is the dysfunctional lens replacement for the refractive lens exchange. Just an example which I am quoting from an article, a 42-year-old gentleman with a clear lens who came with a similar complaint of not a happy vision. Looking at his eye, they found that everything is normal, the lens is clear, even the pentacam nucleus staging is showing no opacities, but the lens index is showing very severe value, the value that is in the very severe range, that is 2.56, which probably explains his dissatisfaction with the vision. The ocular scatter index is the index that quantifies the light scatter then when it passes through this dysfunctional lens. It is again color coded in green, red and yellow with the values given for it. It is measured by a double pass aberrometry approach. And high ocular index, one thing to be kept in mind is that you may have corneal as well as tear film anomalies affecting the ocular surface index. So coming to the primary indication, as we all know, 40 is the age, landmark age in ophthalmology, which creates a lot of change in the refractive error. So anything less than 40, people with high refractive error, either myopia or hyperopia, because of the abnormal ocular anatomy, and who are not good candidates for phakic IOL or refractive surgery, laser refractive surgery, are probable candidates for refractive lens exchange. And above 40, anyone with presbyopia, with myopia or hyperopia, who is wishing for a spectacle independence. So this is one case I recently did. The summary of the patient is like it's more than 50 years, female, hyperop, presbyop, non-diabetic, relatively clear lens. One more case, lesser age group, 40 to 50, 46 years, female, hyperop, presbyop, non-diabetic, done for a professional requirements. So what I look for, or a comfortable patient for me, would be a middle-aged female, more than 50 preferably, a hyperop with presbyopia who is wishing for a spectacle-free life with or without cataract, and there are no other ocular or systemic morbidity that may complicate the vision later onwards, and who may not have much problem with multifocal lenses like less night driving. But I am also concerned about taking away the God-given gift of loss of accommodation when I'm doing it at an age of less than 40 years. And I'm touching an eye which can be refracted to 6 by 6. So I don't want any other errors from my part, and it should be a zero margin error from the surgery point of view. So I should be comfortable doing a proper IOL power calculation. I should be sure that he or she will be good, well neuro adapted to this multifocal lenses, and there should not be, I will not be creating any other retinal complications. So special consideration, I am more comfortable in hyperopic patients. There are not much of things which I need to take care of except for the less space in anterior chamber or a probable primary angle closure predilection. Or see, if you are comfortable with your cataract surgery, probably you can take care of these things. And literature also supports that your cornea safety is better than phakic IOLs in a hyperop, and your higher order aberration profile is also better with refractive lens exchange than hyperopic LASIK. Case 3 is slightly different. It's more than 50 years, but the patient here is a low myope with astigmatism, with presbyopia and non-diabetic. So this is the age group, around 50 is the age group when the myopes start feeling the heat of presbyopia. Low myope presbyopes is a difficult category. They will not be happy with any of these procedures. What I'm saying is that between 40 to 50 years. So what happens is, if with the LASIK, they will be happy with the distance vision, but they are losing the near vision. With the monovision, they are compromising the depth perception. With the refractive lens exchange, they may not be very happy with the multifocal lenses because they used to get a very good near vision without that. So myopes is a different ball game. Less than 40 years, you have to think of options, phakic IOLs, LASIK or PRK. Above 50 years, refractive lens exchange would be a better option. Between 40 and 50, you have to be really careful because these are the patients who will not be very happy. Special consideration in myopes, obviously the retinal evaluation is very important, and these are the patients whom we should not do refractive lens exchange in myopia, the patients with the retinal periphery degenerative changes or myopic changes. RD by all matter is very important consideration. There is almost 8% incidence, especially in the patients with higher more than 10 diopters of myopia and axial length more than 26. We know what are the risk factors. Even a post-operative PC YAG cap also increases the risk of retinal detachment. The literature says that the incidence is more than double in a myope of the same quantity myope who has not undergone a surgery. So chair time and counseling is very important when you are taking a patient up for the refractive surgery, refractive lens exchange. You have to explain the realistic expectations, the durability of the vision that will be recovered, the possibility of the other changes that can happen in the later life, the multifocal related issues, and alternate options should be discussed with them. That includes the phakic IOL and laser vision correction. Or in fact, if it is in that 40 to 50 years, you can even tell them to wait for a little longer time for a better surgical result. And when you are comparing with phakic IOLs, you in phakic IOL definitely have a better advantage of reversibility and can maintain the accommodation, but a further intervention is definitely indicated in that when they become older. If it is with the laser refractive surgery, okay, better accepted and chance of regression is there in laser surgery, but the higher order aberrations make them little less place than the refractive lens exchange. And a laser patient, once they become glass free and later they become cataract and they develop cataract, they may not be a good candidates for a multifocal at later stage, though happen to be wearing glasses at a later stage again. So general principle, what I follow is less than 40 years, high myopes, phakic IOLs, moderate myopes, laser refractive surgery or phakic IOL depending upon the indication, and avoid refractive lens exchange. Presbyopic age, above 40 years, 40 to 50 years, hyperopes, I prefer refractive lens exchange. Low myopes, either LASIK with near vision glasses, monovision or planned undercorrection as per after the discussion with the patient. Or high myopes, go for phakic IOLs or in selective cases, refractive lens exchange. More than 50 years, refractive lens exchange is my choice. So it's the same thing in a diagnostic flow chart. which should be discussed with the patient. The critical steps are counseling, a proper IOL selection, very accurate IOL power calculation, perfect astigmatism-free neutral surgery, zero tolerance for mistake, anticipating and avoiding all possible posterior segment complications, and giving a good tear film balance post-operatively. Intraoperative consideration include, it should be considered as a premium surgery, giving patient all the best possible things during the surgery under topical anesthesia, perfect astigmatism neutral micro-incision surgery, well-placed, perfect centered rexus with good cortical cleanup and PC polish. PC polish is very important because you want to avoid a yak cap at any point of time later also as much as possible. Well-centered IOL and a post-op anti-infective regime. IOL selection, nothing much, but very important that you need not always go for a multifocal lens. It's the patient's choice, what is their expectation and what is the lifestyle. So you can choose between monofocal and multifocal even in refractive lens exchange, but toric IOLs always give the option of giving a, in astigmatism always give the option of giving a toric IOL. You need not target emmetropy in all cases. You can even plan a myopic correction depending upon the patient lifestyle. You are always, most of the cases you are dealing with extremes of axial length. So you have to be very careful about using adequate formulas for an accurate IOL power calculation. And multifocal lenses, they do well in as per literature in even in refractive lens exchange. And to summarize, it's a very predictable surgery result in our with latest IOLs and machines that we have. It has got a wide range of, it can deal with a wide range of patients. It can be a one-stop correction for all types of refractive error. And our targeting, what we are targeting is a complete refractive perfection for that patient. No specific training is needed for this, for those who are already trained for cataract surgery, and more or less stable vision for a very longer period. But patient age, profession, personality, lifestyle, and expectations are to be considered, discussed with the patient, and finally, select the right procedure should be selected. And as we all know, there is no urgency in it. It's an elective procedure. So we have to ensure the best possible result with the highest accuracy, durability, with the least risk that is for that particular patient should be chosen. Thank you very much.
Thank you, Sujith sir, for the detailed and updated presentation.